Okay, let's talk about, as I said, lovely potassium. Potassium is there in sweet things. And we start with hypokalemia. And the major causes of hypokalemia to start with is decreased potassium intake, which is not a usual reason for low potassium, hypokalemia or low potassium anyways. It's not solely enough. Most of the time, there is another reason. Increase entry into cells, because potassium is 98% of it is inside the cells, and only 2% is outside the cells. And what drives the potassium to go inside the cells is the beta agonist, but more importantly, even the insulin. That's glucose itself, anyways. It would drive the potassium inside the cells independently of insulin as well. So all of these things are important. Alkalosis will drive potassium inside the cells to get out some of hydrogen ions. So the acid-base balance is restored. The other thing, increased GI loss, like in vomiting, in diarrhea, in laxative abuse, diuretics. There's something called non-reabsorbable anions, like in keto acids, for example. These are non-reabsorbable. Whenever it reaches to the level of the kidney, they have to go out. And most of the time, they go out with potassium. That's why you could see hypokalemic diabetic ketoacidosis. Alcohol as well could cause the same things. Remember this non-reabsorbable anions. Renal tubular acidosis, as you know, most of them, like let's say the type 1 and type 2 or proximal and distal, usually it's associated with hypokalemia, phosphorescine B, hypomagnesemia, as we just mentioned, and as you know, dialysis is a risk, and plasmapheresis as well. The periodic paralysis is, it's not just hypokalemic, as you can see, it's hypokalemic or hyperkalemic, ferrotoxic as well. If we focus on hypokalemic periodic paralysis, it's usually, most of them anyways, you could see the exercise is a reason or a precipitating factor. But in hypokalemic, like carbohydrate load is a risk compared to fasting. In hyperkalemic, the etiology, autosomal dominant inherited calcium or sodium ion channel problem. This is in hypokalemic. The hyperkalemic is usually the sodium problem. Prevention or treatment, carbonic anhydrase inhibitor could be used, potassium sparing. Again, carbonic anhydrase inhibitor could be used here. So thiazide is could be utilized because it enhances potassium excretion in case of hyperkalemic type. Let's talk about GI loss. The concentration of potassium in gastric secretion is not much. It's like 5 to 10 millimole or milliequivalent per liter. And potassium depletion, again, put this in your mind always. Most of the time, it's urinary loss. So the associated metabolic alkalosis and rise in the plasma bicarbonate and increase the filtered bicarbonate load above its reabsorbable threshold. Let me just make it like simple. Whenever there is vomiting, for example, there is volume depletion, and there is a chloride loss. This chloride loss will, by the end of the day, cause bicarbonate to be reabsorbed at the level of the kidney. This would cause alkalosis. Alkalosis would cause hypokalemia. So not because that the vomitus is containing good amount of potassium. No, because we lost fluid, and that fluid has chloride. That chloride, by the end of the day, cause bicarb reabsorption at the level of the kidney. This alkalosis would cause, potassium shift. This is one. The second thing, it's again, hypovolemia would stimulate, renin angiotensin. Aldosterone. What does aldosterone do? Again, it kicks potassium out. So this is the main two reasons. What about the lower GI? Lower GI has a bit higher level of potassium, like 20 to 50, but most of the time is around 10. So if there's significant diarrhea, that might cause, hypokalemia, as you know, and it might cause, again, non-anion gap or hypercholoremic metabolic acidosis. So that's why factitious diarrhea or laxative abuse, this is a risk for, hypokalemia, though they might have metabolic alkalosis. Other conditions like a prolonged period of villus adenoma, VIPoma, and infectious diarrhea as well could cause that. This is the collecting duct, and this is what we call the principal cell in the collecting duct. This is the mineralocorticoid co-transporter where the aldosterone is working. And this is the epithelial sodium channel that we call it ENaC. This is where the Liddle disease is, or syndrome is happening. So imagine that there is loss of sodium by any reason. You're giving Lasix, for example, or you're giving thiazide. So all of these would cause sodium loss at the level of collecting duct. This would be sensed by the ENaC. ENaC will see this, that if it continue, that this patient is losing sodium, will be shocked. So what ENaC do, that it will reabsorb sodium. And at the same thing, that aldosterone will be activated because there is loss of sodium. It means loss of volume. So aldosterone will do two things: will activate the 3-sodium potassium ATPase and activate as well the ENaC, and probably bringing more of these channels as well there. What would happen? So sodium inside is high. This will see it, will take it inside. 3 sodium, 2 potassium. So the thing is, you give sodium, let's say that you're giving saline, not Lasix. You're giving just good amount of saline. The kidney will protect you. You're giving too much saline, it will not stay inside. So the kidney will just get rid of it. Again, it will be sensed here. The sodium, the saline will be sensed here, and it will be reabsorbed. Again, this will activate the mineralocorticoid co-transporter, and potassium will be get rid of. We started, let's say that your patient is hyperkalemic, for example, saline wash could improve that hyperkalemia because of this mechanism. You know that why we're so optimistic about potassium, because it affects the the heart. At any, you could see at any level of those arrhythmias like PACs, PVCs, sinus brady, to the level of VTAC and fibrillation, and the U wave of hypokalemia that is usually following the T wave. The thing is not just the level of potassium, it is the rate of reduction. That if the reduction of potassium was rapid, this is arrhythmogenic. And it could affect the kidney as well, by what's called ADH resistance, like impaired concentrating ability and altered sodium reabsorption, hypokalemic nephropathy, that is a reason for interstitial form of nephritis that even could cause CKD. Let's go to talk about treatment. The first question you have to ask yourself if there is hypokalemia: is there emergency that I should urge myself in treating this patient or not? And you specify the goal, which is prevent or treat life-threatening complications, as you know, arrhythmias, paralysis. I think you've seen by now people who came, they were literally paralyzed because of significant low potassium. Either it is periodic or any reason for significant hypokalemia. It's a reason for rhabdomyolysis. hypophosphatemia and kalemia reason for rhabdomyolysis. So just keep that in your mind. The other thing is you need to know how to replace the potassium deficit, and you diagnose the reason for hypokalemia to prevent further, repeated episodes. And how urgent you have to act depends on the severity, depends on the rapidity of low potassium, and if there is comorbid condition or not. And remember that the risk of arrhythmia is highest in those categories: older patients, patients with organic heart failure, patient on digoxin or on antiarrhythmic medications. Let's just cut it short. Any drop of 0.27 millimole below 3.5, this means your patient is deficient by 100 millimole at least. It's written milliequivalent. Milliequivalent and millimole is the same in monovalent solutes like sodium and potassium. But in a chronic hypokalemia, in fact, this deficit might be even more. Have anyone asked him or herself why we give potassium chloride? We can't give potassium bicarb. No, because there's something unique. In hypokalemia, many times you could see chloride depletion. So if there's a chloride depletion, there would be a problem. Let's just focus on the distal convoluted tubule. This is the sodium chloride channel. It is the thiazide channel, in fact, or thiazide cotransporter. Imagine that there is no chlor inside the tubules, the urine. So this will not work. So sodium will be lost because there is no chloride inside the urine. Then again, bicarbonate here is secreted to the urine. If a chloride is not there in the urine, this would cause alkalosis. So alkalosis, we started with low chloride and we ended up by alkalosis. Alkalosis is a reason for hypokalemia. That's why if you were not able to correct the chloride depletion, alkalosis will not be corrected. Potassium will not be corrected. That's why we give potassium chloride most of the time rather than other solutes. Anyway, sodium will be lost and will be sensed by ENaC again, will activate mineralocorticoid to reabsorb sodium and to get rid of potassium. Again, this is so double effect. Alkalosis, mineralocorticoid will be activated to get rid of potassium. When we think about mild to moderate hypokalemia, like 3 to 3.4, how do we treat this? It depends. If it is just GI loss, maybe, as we've just mentioned, potassium chloride orally would be fine. If there is, sort of acidosis, you can think of potassium bicarbonate or citrate. How much we give? We give, I think all of you know that we give, the tablets has just few millimoles. That's why we prefer the liquid one, because it has 1:1. 1 ml has 1 millimole of potassium. So 10 ml has 10 to 20 is good to start with. 2 to 4 times, you can reach like 80 per day. And if there is renal potassium wasting, the problem, you give potassium from one end and you lose it from the other end in the urine. That's why most of the time you need like potassium sparing agent. What about severe hypokalemia? Like potassium must be given to the patient, and you don't need to wait. Severe is less than 2, less than 3. In fact, 2.5 to 3, or even less than that. Anyways, usually they are symptomatic. What I would recommend, I would say this is one of the very important slides. When we talk about potassium, I usually ask this question: what is the maximum potassium you can give per hour? Most of the time, the trainees answer wrongly. because I'm not asking about the concentration. I'm asking about the amount of potassium you can deliver to your patient per hour. So we have two things. So the first thing, the maximum, you can give 10 to 20 millimole per hour. The you can give 20 per hour. People said if there is life-threatening, you can give even 40 per hour, but I would just delete this. I wouldn't absorb it, believe me. So more than 20 is highly irritant for the peripheral veins anyways. High rates should be infused into large central vein or into multiple peripheral veins. And the concentration, it depends on the amount of the fluid bag you have. If you have 1 liter size container, preferably is non-dextrose. The reason is dextrose, we said that it will push potassium inside the cells. You need it without dextrose. And the maximum you can put is 60 in a liter. If you have smaller bags, 100 to 200 ml peripheral vein, you can give 10. What about central vein? You can go up to 40. Preferably, you use the infusion pump and preferred with any intravenous container that has more than 40 millimole of potassium, or if the desired rate of potassium administration is more than 10 millimole per hour. Renal tubular acidosis. You name it many times, like proximal or type 1 or type 2, sorry. And I get confused many times, which is type 1, which is type 2. So it's good to know which is which. So proximal renal tubular acidosis, or what you call it, type 2, is the one that causes loss of bicarbonate in the urine. And it's less severe compared to the distal one. And and we know that diagnostic approach for the proximal one, that we give bicarbonate, we see that, I mean, infusion, bicarbonate infusion, we see the level of bicarb is improving, and then you have acidosis again because the urine is full of bicarbonate. So there is a problem in reabsorbing bicarbonate, and it's they say that, you know, the kidney, after losing significant amount of bicarb, will just wake up and say, well, we need that bicarb, just reabsorb. So there is a threshold. When it is reached, the kidney could reabsorb some of the lost bicarb. And the distal RTA, we call it like inability to acidify the urine. There is a problem in secreting the hydrogen ion at the level of the or intracollated cells anyway. Which is more severe is the distal RTA. Most of the time, the urine pH is less acidic, more than 5.3 compared to the type 2. And usually, the potassium in distal RTA has, low potassium. It could be corrected when you give bicarb anyways. And in type 2 or the proximal, you might have normal potassium. Which is associated with nephrolithiasis, of course, is the distal. Which is associated with autoimmune diseases is a distal. You know, why do we care about this? Let me just mention this case. I got a patient who has pancreatitis. That patient, she was referred to us because she had metabolic acidosis. It was non-ion gap metabolic acidosis. So we said, well, this is an autoimmune disease. And she eventually had Sjogren and lupus, in fact. But the diagnosis was, not the usual way. It was just because of RTA. Let's talk about hyperkalemia. Potassium journey is an important journey. Potassium load from the food will stimulate insulin and beta-2 agonists to get, a more active sodium-potassium ATPase. Insulin is the, is the strongest stimulus for sodium-potassium ATPase. So this would cause potassium to move, mainly inside the muscles and partly to the liver. And some of the ingested potassium, of course, will stay in the extracellular fluid. Mild elevation in that plasma potassium concentration, in fact, will stimulate aldosterone and eunogastric. ENaC will be activated, the mineralocorticoid will be activated, and potassium will be secreted. So in like 6 to 8 hours, the potassium should be dealt with. Whenever you have high potassium, you have to rule out pseudo hyperkalemia. Pseudo hyperkalemia, you have to ask your patient, how was the, extraction? Was there fistic clenching? Lots of fistic clenching, tourniquet was used, and the extraction was difficult. If it is yes, that could raise potassium by 1 to 2 millimole, in fact. In pseudo hyperkalemia, most of the time, acidosis is not there compared to true hyperkalemia. True hyperkalemia, most of the time, is coupled with acidosis. In leukemia, for example, as well, there is a phenomenon in acute myeloid leukemia that could cause hyperkalemia, which is in fact pseudo because of the fragility of cells. However, hypokalemia is more, in fact, with the myeloid leukemia because the rapidly proliferating cells, they consume potassium. That's why you see hypokalemia. So in those patients, there's something unique that if you send the sample, which has lots of white cells through the pneumatic tube system, this would cause more fragility, will be a reason for releasing potassium and causing pseudo hyperkalemia. Just put that in your mind. Beta blockers. Beta blockers, especially the non-selective ones, propranolol, labetalol, compared to like atenolol or bisoprolol, those are selective ones. The non-selective ones could cause more chance of hyperkalemia compared to the selective ones. But that one is not anyway that high, usually less than 0.5 millimole per liter. But it's not usual reason. If you have like multiple medications and beta blockers are on board, don't put beta blocker as first or second or third reason for hyperkalemia, but just keep it in your mind. Exercise. This is very fascinating slide. You know that slow walking could increase your potassium by 0.3 to 0.4 millimole per liter. And if that walking came to be moderate or even like in marathon runners, that this would increase it above 1. And even 2 of that reach to the level of exhaustion. That might cause ECG changes, lactic acidosis as well. That's why there is something important. We hear many times that people, they were, playing soccer, for example, and they just fell down in the field and they died. The first thing we think of is HOCA, hypertrophic cardiomyopathy. It's not necessarily. It might be just because they did not condition their sodium-potassium ATPase. What does this mean? It means that this sodium-potassium ATPase, it needs like, exercising them before you start, strenuous exercise, and then they don't cope with getting potassium inside the cells as the rate which is needed. So it's important to do the exercise before, going to strenuous exercise or effort. Otherwise, sodium-potassium ATPase are not enough, to deal with the leak potassium. Now that might cause problem. That might kill, people, and no one knows what was the reason. Especially if those they are taking, for example, non-selective beta blockers, that would be a risk where they have renal impairment. Other reasons, digitalis overdose is a reason as well. for hyperkalemia because, you know, digoxin, it works by inhibiting sodium potassium ATPase anyways. Some of those, you know, beautiful flowers as well. What about red cell transfusion? You know, it shouldn't cause hyperkalemia in, you know, adults, let's say, if the transfusion is not hypertransfusion. If it is hypertransfusion, yes. Like in trauma, for example, during OR, for example, that might be a risk. And infants could have hyperkalemia because of transfusion. Pseudo-hypoaldosteronism, there are two types, in fact, without going into the details. It's either like in ENaC or it's in the mineralocorticoid. Anyways, the hormone is there, which is aldosterone, but the receptors are defective. That's why they could have hyperkalemia. So what is our approach? Is there emergency? This is the first thing you should ask yourself. Is there emergency? Emergency, it means your patient is having paralysis, for example, or there is problem in the cardiac conduction. So is there or not? If it is not there, then ask yourself, what is the serum potassium? Is it 6.5 or more? Because if it is 6.5 or more, this is the time you consider giving calcium gluconate, even if there is no ECG changes. So ECG changes, calcium gluconate is there. But if the ECG is not being changed, but the potassium is 6.5 or more, don't wait. You will give calcium gluconate. Anyways, so the question, if there is no paralysis, there is no conduction abnormalities, then the serum potassium, is it more than 6.5 or not? If it is no, then ask yourself, is the serum potassium more than 5.5? Is there significant kidney function problem? Is there ongoing tissue breakdown? This is very crucial. If there is rhabdomyolysis, there are tumor lysis, there is lysis from anywhere, then you have to put that patient at high risk for, you know, refractory hyperkalemia and prepare your weapons. So if the potassium, again, is not above 6.5, it is above 5.5, but there is no any one of those, like no renal impairment, there is no tissue breakdown, and then this patient, you could slow down their potassium, you know, slowly and without, you know, being panic. But if, yes, the potassium is more than 5.5, then you ask your patient, does the patient have severe kidney function, dysfunction, or oliguric? If no, does the patient need to be optimized for impending surgery, for example? So potassium is above 5.5, there are no risk, but he's going for surgery. Yes, at this time, maybe I need to shift the potassium, make sure that there is no reason, ACE or ARB on board, or there is no hyperglycemia, for example. I need to correct all of those before going to OR. The other thing, no. What about if there is hyperkalemic emergency? Your patient is having respiratory compromise. Your patient is having, for example, paralysis, or there is a problem in the ECG. So immediately you go with your weapons. What are the weapons? We spoke about this, that true versus pseudo, and level of potassium is important, ECG changes or not. I will just classify them into first rapid response and second one. The first rapid response, you should do immediate blood gas. You have hyperkalemia, immediate blood gas is a mandatory to see what is there acidosis or not. So bicarb will help you. The glucose level is very important because we said that the one that will, you know, will fire the sodium potassium ATPase, will make them work efficiently is insulin, the first trigger. So if the glucose level is high, it means there is insulin deficiency. It means that giving insulin would save your patient. Calcium gluconate and D50 insulin beta-2 agonist. And the second rapid response, volume assessment. You remember that we mentioned that potassium, to get rid of at the level of collecting duct. It needs sodium. Pushing sodium will get rid of potassium. And volume assessment would tell you, should I give a fluid or should I give diuretics? Potassium chelators and renal replacement, it depends. Most of you know that we have hyperacute T wave, which is ischemic or non-ischemic. And by the way, the hyperacute T wave of hyperkalemia should be narrow-based. Differentials are there. Hypomagnesemia is a reason as well for tall peak T wave. Golden tips, calcium gluconate to be only given if potassium is more than 6.5 or 7, or there's ECG changes. The least amount of glucose needed to cause good potassium shift is 60 grams. Please take this and just circulate it everywhere. The 50 ml you give, like D50, 50 ml in hyperkalemia has only 25 grams. This is not enough. This is not enough. You need to give 2 ampoules most of the time. It depends on the glucose level, of course. So 100 ml D50 barely has 50 grams. However, if patient already has severe hyperglycemia, you might not give. The amount of insulin that is perfectly, because transcellular shift is in fact 15 units, is not 10 units. But if you give like 15 units, it has to be over 15 minutes. If you give 15 units, it has to be over 15 minutes. And you check the blood sugar every 15 minutes for 2 hours. Loop diuretics are very helpful. But if patient is in need for volume expansion, give isotonic fluid first to enhance the distal sodium delivery. And the principal cell at the distal nephron will do the job as secrete potassium. When would you repeat? You shift the potassium right now. You don't wait like 4 to 6 hours. The first repeat has to be in 1 to 2 hours after initiation of treatment, and then accordingly, if potassium is subsiding, there is no risk factor, there is no lysis from anywhere, the risk that would be very high, there is no renal impairment, or vice versa. And make sure that you repeat it in the right time. The serum glucose, those who receive insulin with or without dextrose should undergo hourly glucose measurement for up to 6 hours. And as I said, when you give 15 units, you do it every 15 minutes in the first 2 hours. The calcium gluconate is short-lived. So if you give it, it will have like 30 to 60 minutes. You could redose whenever you need, because if you give it and there is no effect of it, it means that it did not work. You need to redose your patient. You have 2 types, calcium gluconate, calcium chloride. Anyway, I'll just skip this. Think we mentioned, yeah, if the blood glucose of your patient is 250 and above, you don't need to give dextrose at that time. You can give insulin, and then you should measure every hour for 5 to 6 hours and see. And the ECG changes, you know that peak T wave, drop B wave, widen QRS to the level of sine wave. And the onset of action for those are, the anti-hyperkalemic measures are, calcium gluconate should work immediately to stabilize the membrane. Insulin will take like 20 to 30 minutes, and beta agonists will take 15 to 30 minutes, but it's not as strong as insulin. Sodium bicarb could be as well shorter, and the dialysis, of course, will remove potassium immediately.